Hi, I'm Joan Gregory, and this is Climate Changes Health and Health Equity. It's a series that we've been offering here at Eccles on Sciences Library, and an 8-session series. And now we are on kind of the ending, the final 3 sessions. We're now focused on solutions and actions that we can take. Some of those are actions that we can take as healthcare professionals. Some are actions that we can take as students or faculty or staff at the university. And others are individual changes or actions that we will make. Today's session is focused on practicing green health. And we are going to learn about both the impacts of climate change from the healthcare perspective, the healthcare system perspective. How does the healthcare system impact climate change? And learn also about how University Hospital has taken steps and is in the process, a process that you might want to get involved in looking at what their impact is on climate change here. Our speaker today is Dr. Smitha Warrior, and Smitha is a board-certified anesthesiologist and assistant professor clinical of anesthesiology in the School of Medicine at the University of Utah, with special interest in general and regional anesthesia, especially as it applies to patients with acute perioperative pain. Dr. Warrior also serves as the medical director of anesthesia for the Ambulatory Care Center, and she's president of the Utah State Society of Anesthesiology. Smitha is also passionate about environmental sustainability, especially in healthcare. So let's put our hands together and welcome Smitha Warrior.
Thank you, guys. Thank you, Joan, for having me be here. Joan and I met very serendipitously and very randomly at a microaggressions workshop that the university was hosting, and became fast friends. And if anyone lives environmental sustainability, it's Joan. So she's been a tremendous inspiration to me in this journey that I'm on for figuring out how to make an impact in a positive way. So like Joan said, today I want it to be really interactive. If you guys feel free to interrupt. I'm super casual. If there's anything on there that you can't see or you have questions about, and I'd love to save a ton of time at the end for questions or discussion. I'll switch from this kind of PowerPoint type presentation to going through, as Joan mentioned, an initiative we're trying out at the hospital called Practice Greenhealth. It's a membership that we've joined as the university system, and so we'll kind of go through that towards the second half. But I don't think in this group I have to convince people that climate change is occurring. But it's been a depressing day. I read this morning that we are pulling out officially of the climate accord today. So there are people who obviously don't realize the impact. But assuming we're not that crowd, this is just a graph, I thought it was a great graph, just easily showing kind of who has been involved and really the offenders of climate change over history. This is from 1850 to 2011. And clearly it's kind of the developed nations in blue, the developing in yellow, and it's the United States and the European Union are by far the biggest offenders. China is in yellow, but again, this is data from 2011. They've made really big jumps in becoming big offenders or causation of climate change. So that's a little bit outdated, but interestingly enough, I can't get rid of any smart people in here that my screen, there we go. Oh, every time I touch it, it goes away. I'm going to stop touching it. So this graph is almost the inverse of the last one we just saw, and this is who is affected the most, who is the greatest sensitivity, and who's hurt by climate change the most. And it's the opposite, right? We have lots more yellow here for the developing countries, and we are by far the biggest contributors, but the least affected. So it's very disproportionate. And health disparity is a whole different discussion and large topic. But where we fall into this is that in the US specifically, but in general in the world, healthcare is a significant cause of climate change. The World Health Organization in general has been focusing on this and has labeled it, along with many other organizations, Joan sent out some references, but as the largest global health threat of the 21st century. The US healthcare is the second most intensive energy user in our world, and there are lots of points up here. We are a significant contribution to waste. I work in an operating room as an anesthesiologist, and if you've ever been in one, you will see each patient, the amount of waste that generates is amazing. And so we are a significant source of waste on the system. We obviously affect water with our pharmaceutical waste, but again, energy intensive system. So healthcare, again, if another way of kind of looking at this is, and this is old as well, we just don't have we have till 2016, but the numbers on the y-axis on the right are thought to be in about the 13% range now. But if we were considered as a country, just healthcare in the US, not the US, but just healthcare, we'd be ranked 13th in the world with all the other countries of greenhouse gas emissions. So we're a tremendous source of climate change and greenhouse gas emissions. And a lot of this talk and the data is going to be focused on greenhouse gas emissions. And the reason is there's this article, a lot of my slides, I have to give credit to Jody Sherman. She's an anesthesiologist out of Yale. They have a great department at Yale where they have worked with environmental engineers very closely to harvest a lot of this data and to put it into terms that are representable and understandable. But there's a lot of things that we're doing with our society, with our population, with our industries, but global warming has the significant portion of the weight that's contributing to our problems with climate change. So there's all these factors: smog formation, ozone depletion, which is actually a success story, but that's another story in terms of our initiatives and changes, but water intake. All of these things are things that when you talk about how can we make change, you're going to say, well, isn't that bad for the water, or isn't this? We have to focus on something that we can affect change with, and right now greenhouse gas emissions are our biggest offender. So that, if you're asking why we're talking specifically or a lot about greenhouse gas emissions, that's why. It's our biggest contributor right now to health and climate change. Sadly, we are also represented poorly on this chart as in who fights climate change, who is doing something about it in terms of focusing on emissions, policy, energy use, and investing in renewable energy. And we are in the red, which is not a good thing. Even countries like Morocco, Portugal, very high. India, who is, by population census, a significant source of climate change, has made very significant actions and policy changes over the last few years. So they are actually in the green, which is a good thing. The European Union is mainly in the green. Sweden, Finland, Holland, that area. The UK, Ireland is that little red guy off there, so they clearly have a different policy groupings than their neighbors in the UK. But we're not doing well, is the point. And, you know, especially on a day like today when I wake up and I read all these horribly depressing things like how we're not going to be part of the climate accord, that's one thing, and I can't do anything about that besides being involved politically. But what we can do is kind of focus on the system we're in and try to make an impact. And Scientific American, this was just last week, it's just a screenshot, but it said, I think there's a lot of statements, but including a moral obligation as the providers of health and as kind of the beacon of health to say, we should do something about this and that this is a problem. Whether policy is hearing or not, we have local effect that we can take in our states, but we also have our institutions that we can take charge of and try to make change. And doctor, physician, MAs, all of us, whatever, anyone working in healthcare, we're all there to do something good for people and to take care of patients. And as physicians, we take an oath to first do no harm, and I think we've been steeped in that for hundreds of years, that we're here to take care of patients. I remember when I was in medical school, we saw a video that was taken, we think, around the 70s of physical exam. It was very early in my first year, and no one focused on the video. All anyone remembers was the fact that the clinical exam, including the rectal, was being done without gloves. And it was one of those moments where you're like, wow, we've come a long way in terms of worker safety, right? Like, there's all these things we do now to protect ourselves. Eyewear, all these things, but we are still very, very new in this realm of how are we affecting our community and what is our public health impact of what we do in the hospital. And that's where I think, again, we're making the case here that that's where we need to absolutely be moving towards. One of the ways that we can actually look at how we're affecting health, because it's so nuanced, right? Like, yeah, you breathe that air, but maybe you just had bad lungs, or you were asthmatic as a kid, so we're not really making you worse. This was going to be your natural course. But one of the things that people are looking at now is it's daily. It's the disability adjusted life year. So it's a measure of your overall disease and then the cumulative numbers of your loss based on your quality of life or early death. So they take your healthy years and then they say, these are the years you were living a poorer quality life for various reasons, and these are how many years of lost lives you have versus your expected outcome. And the U.S. health sector alone, just focusing on us as health, the estimates have been, again, from 2016, around, again, up to 675,000 disability-adjusted life years per year for all types of climate change factors, not just greenhouse gases. And if anyone remembers, in 1999, there was a very, very important article that came out about to err is human, and it really highlighted the errors we make in medicine as being a patient safety issue. And we're all here to help people, but the errors we're making with drug switches and all these things, infection control issues, created to a significant number of morbidity and mortality in our patients, and that we needed to really evaluate the medical system to make sure we weren't hurting people. This is now on the order of that magnitude of where pollution is really the new patient safety kind of issue and mantra that we should be focusing on. This came last week. I was looking at India because we're flying there for Christmas. My family is originally from India, and in Delhi, the kids have been out of school for over a week now. People are really not asked to be outside, and they actually do have great policies in place. Your license plate is an even or an odd, like in Mexico, so only certain people can drive on certain days. And still, because of population issues, they are predicting 1.5 million people by 2100 dying because of climate change issues. So that's kind of my start of, like, it's important. It's not just what we do every day at home. I'm sure all of us in this room, I'm preaching to the choir. I yell at my kids about where they put their garbage, and they're 3 years old, and I'm chastising them about the recycle bin. But then I come to work, and it's like, oh, here you go. I can't even find a recycle bin in our eating space in the operating room, much less, in the ORs with our clinical care. So in my world of anesthesia, there's a lot of things that we are working on. Right now in the world of medicine, people are really moving towards single-use disposable devices in every sector of medicine. And a lot of that comes from various factors, which we'll talk about. But these are things that we use to intubate people, to put in breathing tubes when you have general anesthesia and you can't breathe for yourself. So the right side is the single-use disposables, and the left are the reusables. So different cleaning requirements. Industry regulates. This is another problem that we won't get into, but industry is the determinant of how something gets cleaned and what the classification of cleaning for equipment is. And it's a lot easier for them to say that it's easier to throw it away when they're making all these new products and getting paid for them than to create a very cohesive kind of cleaning standardization. So when you take any object, and we're talking about reusables or material in general versus single use, this is, again, Matt Eccles is out of Yale, and he's with an environmental engineer that looked at it in life cycle analysis. And it's not just, we focus on that circle of how it's made, how we use it and where it goes at the end of that life cycle of the product. But really the raw materials that we're using to make these products, the industry process in which we make these things, and then how they get transported, as well as how it gets used and disposed of, is the entire life cycle of a thing. And some of them are not intuitive, and they're easy to overlook, and they're not involved in our decision making of how we purchase supplies, especially at a hospital. People just think about how does it get thrown away. But they did a study at Yale, again, where it's kind of complicated, but these big gray bars are the single-use disposables. And they looked at what the life cycle portion, they looked at each portion of the life cycle and where the emissions for greenhouse gases were occurring. And for single use, the big high bars of increased greenhouse gas emissions were really in production, transportation, and packaging. Then you're like, oh, well, that's okay because maybe it's going to save costs. No, of course it's not going to save costs. So the gray here is the single use. You're purchasing these things over and over every time, not to even, and again, they looked at waste disposal fees. They really looked at every aspect of this. We talk about, well, you're throwing that away. We're no longer throwing a lot of our trash away. We're incinerating because we don't have landfill space. Many states have absolutely no landfill space available, so they're incinerating everything, and we pay for all that. But even with all of that in account, just the purchase price of the single use is significantly higher. So you're spending more and wasting more and creating an impact. And why would people do that is the question, and a lot of it's fear. Especially in medicine, we are still focused on, well, what if we have an infection? We have all these accrediting bodies, JCO, DMV, that are coming by with, to be honest, not a lot of evidence-based practice guidelines for these things, but fear. And in this fear, we have to remember, I try to remember, I should tell myself, that they're here to try to do good and to protect patients. But at some point, we've lost that line where every patient we take care of is negatively impacting our community and our public health. The fear is unfounded, right? This is what everyone's worried about happening. But if you look at infection rates over the last couple centuries, lots of big changes, right? Penicillin, sterile hand washing technique, the ability to sterilize instruments, things like that. But gloves and masks, those were huge downshifts in this curve. And survival, you can see just for amputations, went up dramatically. But this red line here is, we're not getting, there's the impossible ask of getting to 0 infections, especially when our volume is increased and the complexity of what we do is increased. We're also taking care of sicker patients. So the factors that are infection are not just contamination, but patient population, risk factors in terms of health, morbidity, complexity of cases, which have all changed over the centuries as well. And what happens is, over time, if you look at, as we turn over inventory, yes, we are approaching 0, but we've been approaching 0 for a while. We're not actually affecting the risk of infection rates. What we're affecting is our disease burden, our indirect burden, by all of the product we're consuming, all the trash we're creating, all the greenhouse gas emissions we're generating by doing this. And this is all super depressing. So we're going to go to some happier things here, because I spent 2 years trying to change our circuits over the anesthesia machine. So I did surgery for 3 years and then anesthesia. And so I have this interesting perspective, and it's much different on my side of the drape, so to speak, than it is operating. Operating, you don't really know. I felt like, this is my opinion, that I didn't know how much I was using because I'm putting my hand out and it's being given to me, and I'm not looking in the garbage cans until I throw my gown in when I'm done with the case. But when I'm actually opening every piece of package as an anesthesiologist, every syringe I use, and you feel it every time you open it, and my garbage can fills up by the end of the case, like it's a very different, palpable thing that I feel as an anesthesiologist than I did as a surgeon. But I tried to spend 2 years trying to change our circuits over to reusable circuits, and in the end, the nursing, the techs that clean our equipment just felt like it was going to be icky, was the word that was used. And so things after 2 years did not work out. But the bright side is there are things I'm sure we can all do. And figuring out what your high impact things and whatever part of the hospital world you live in is important. I heard some talk over here before, but anesthetic gases are a big contributor to greenhouse gas emissions. We put people, historically, ether was the first gas that we put people to sleep with, and now there's multiple. But they're all extremely noxious to the environment, and our greenhouse gas emissions have significant emissions that last around for years. So the main anesthetics we use these days, one is desflurane, one is isoflurane, one is sevoflurane, and they have very different impact factors. But for convenience sake, and for lots of pharmacologic reasons, people like to use certain ones. Of course, those certain ones are the most damaging. It's the equivalent of using that gas for an hour of anesthetic, like a simple case like an appendectomy is like driving 400 miles. And then on top of that, depending on how much oxygen you're using or not using, can take that up to 600, 800 miles just in an hour. It's also been shown that these kind of anesthetic gases linger in that layer of the ozone for years and years and years, way longer than some other substances do. So the UK has a National Health Service. So the reason they were green on that chart way before is they've bought in, as a country a long time ago, that we're going to do something about this. So their National Health Service is tracking a lot of things related to healthcare as to how they're impacting the greenhouse gas emissions. And 2/3 of their greenhouse gas emissions come from procurements specifically. But again, if you look at an entire hospital system, the fact that I can point to one thing, anesthetic gases, as 2% is a significant volume for the entire country to be putting out. So they have done a ton of things. This is just one example of one hospital and what they've done really over the course of a year. I don't know if that's coming out kind of grainy, but they did things where like they paid people to not park. Instead of providing more parking, they paid them to not park, so they found other ways of commuting to work. They changed their water, they changed out their LEDs, they waste systems, and most of these things led to cost savings. Again, savings about 14 million pounds. But their carbon footprint reduced by 65%. So there's tremendous amount of potential that can be done if the system is invested in making change. These are some success stories of anesthesia where, again, this pie, I have another graph that's better, but the pie makes it look like they're now just consuming more energy, but they're actually changed their gases and their emissions significantly decreased. I think this graph's a little bit better to show, this is CO2 equivalents on the y-axis, and to show over 4 years the significant decrease. And this obviously is not so much, this doesn't affect patient outcomes. This is a personal clinical decision as to what's made, but that doesn't have clinical outcome effects on patients. So win-win. And not to mention cost savings. So in our institution here at the U, my previous chairman, he made this kind of assessment and we all switched as a group. And in that first year, we saved $700,000 in addition to the significant decrease in emissions that we created. So as a department, we saved $700,000 just in that first year. So big changes can also have big financial impacts, which the institution loves to hear. So it's nice to tie those things together sometimes if doing the right thing isn't enough of an argument. Because there will be other things you have to buy into. And so then saying like, in this area, you're gonna use those resources, but to get rid of styrofoam, that money we saved as a department should go towards spending money on things we know are more sustainable. Kaiser, of Northern California, again, just changing that one gas that we discussed, the inhalational agent. They had an overall 39% reduction in their greenhouse gas emissions. The big blue bar that they still need to work on when I look at this is their use of one of their other gases, nitrous, which is also a big offender of greenhouse gas emissions. But this is, I mean, so there are things you can do. There are things you fight for that don't always work out. A lot of them can save money, some of them don't. But there are things that each individual group, I'm sure, can do. I see food services represented here, and they've been doing some amazing things in the hospital that I didn't get to learn about till recently. But I think communication's important too. But again, letting your system know, that these things matter is something everyone can do. And to your managers and to people and knowing that we're causing problems, but also knowing that there's so much data out there, and hopefully we're going to talk about that next. But there's lots, I think just talking amongst colleagues and managers and things like that will help, speed up this process of trying to get our system as a whole to be involved. And then with some of you in the room here, one of the things that we're doing as a hospital is, and this took 2 years too, but it was successful. Now we have to do something useful with it. There is a group called Practice Greenhealth, which is what I kind of played my title off of. But they have 3 arms. They have Practice Greenhealth, which is kind of a hospital-based membership, so that you can get tips for every part of the system. You can get an infrastructure set up of how they've gone through these things, previous hospital experiences, supplies and vendors, of which they also have a complete Greenhealth exchange system, which is purely for the S&P supply and purchasing departments, so that there are vendors that are vetted for using green, environmentally friendly products for whatever it is that you're buying. And then there is Healthcare Without Harm, which I totally recommend everyone going on. I'm not like a social media person, so I've been getting on social media to try to do this kind of stuff, but it's a great group of providers, health doctors and nurses that are really making change, and it's a great way to just get ideas about what you can do, what's been successful, and not reinvent the wheel for all these things that we're all trying to do. We started our Practice Green membership, and this one I'm scrolling through is their proposal for the U. And so, excuse me, but the business case is what they started with, of course, is that they're going to save money by doing this. But it's actually impressive. If you look at the return on investment in the hospitals that these guys consult with, just for an operating room, if you make the changes, again, not every hospital is going to be willing to make these changes, but you save about $47,000 on average per operating room per year, which is huge return on investment. If you do things per facilities, then the savings go way up. Some of the groups that big hospitals, Mayo, Cleveland Clinic, Yale, all of them have savings for investing in different things. I think it was Sloan Kettering that it was, they saved $3.3 million changing their HVAC systems out. It was Hopkins that did the Healthier Food Challenge, and they decreased their meat and improved their plant-based offerings by about 15%, and also showed cost savings and obviously improved health in what they were offering through their food services. So there's lots of avenues for using the system. One of the things that I noticed, and it was concerning but reassuring at the same time, is these are a lot of the hospitals that do it. I had them pull our medical school and teaching hospitals that were on par with us, because I wanted to show that academic institutions do this too. But all of these places in our region had already been members, which is interesting. Now, the membership alone does not mean that anything's going to happen without, again, every person in the institution, or at least some champions, working towards it. But these things are catching on. I mean, Practice Greenhealth is not that old. It's I remember trying to look at them 2 years ago, and their website was horrible, and it was hard to even get in touch with anyone. And they've grown tremendously, and I think they've done a really good job and saved money at the same time, so people have gotten on board. But it's great to see kind of the investment of these groups to try to at least get on board and to figure out how to do it. And this is one of those places where I say with Intermountain, like, this is where we partner, not compete, but we try to figure out how we can all be better, because we're all living in the same community. We have, what was the one other thing I was going to show? This is kind of the way they look at it, right, is that you find a community, all of these things are influencing each other to eventually, at the core of it, healthy people have a healthy planet. We have a membership, like I mentioned, that is through the U, that's now there. And they have great tools. So they have educational topics, they have webinars. We get all these kind of emails about upcoming things that you could pay attention to or be involved in. And they have a tremendous amount of resources. For me, where's the greening? They have like an entire topic, I probably missed it, on greening the OR right here. And they walk you through, I think I missed it there, but they walk you through what are some easy steps individuals can take if you don't have relationships with leadership or management in your own operating room. Like, again, for me as an anesthesiologist, just switching the gas I use is something I have complete control over. Or other things you can do as a system within your operating room to get your managers involved. There's a nursing climate challenge that they go through. For any of you that are in the hospital system, everyone should be able to log on to this to get ideas. And what we're doing is kind of building our community within the hospital of people who have been doing this work for a long time, that are invested in doing it, and creating a committee. Chris Nielsen here, I'm going to call him out, is one of our medical students, and he's been really active in getting the students involved. And I really think that's going to be, the generations below me for sure are more aware and more invested. And I think if we can educate, I didn't get any education on kind of environmental impact as a medical student, but if we can start educating them early so that when they start their practice, they're already practicing with a mindful approach and making choices and asking the right questions. I think that'll lead a lot of change in advance. So I think this is a great spot for us to start as an institution. My goal will be able to create an infrastructure that then gets carried on. I think that there were lots of ways to go about this individually, but there is no long-term sustainability kind of leadership that we had set up at the institution. And if we can start with that, then no matter who's here, I mean, Joan's a tremendous champion, but when Joan's gone, or if I move, or if Chris goes away for residency, that there is a system in place that someone's just going to fill that spot, and that this will continue on as a system, and it's a priority of the system. And so far, I think the system has been really responsive. They have never been really approached in their eyes about how they could impact the community for better by changing their ways. So it's been a good conversation to have. I think everyone is clearly on board for this kind of behavior. It's now a matter of how do we get it done. But hopefully, again, we'll be able to utilize, we already have been committed to kind of renew our membership for next year, even if we don't create any cost-saving measures. The first year is really about getting settled in it and getting the structure in place to carry out some of these things. So that's what we're doing right now at the U, and hopefully it will continue to grow and strengthen, and we'll find climate champions in every part of the sector to kind of create, more use out of this tool. That's it. That's all I got. Questions? Yeah.
So does anyone want to ask the first question?
Well, sounds great, but I came in a little late. But which group in the healthcare system is sponsoring this, and what kind of ongoing sort of promotion and discussion is there?
So, sorry. And it might work better for you to pass the microphone. Okay. I've kind of hacked my way through trying to figure out what the best. I mean, honestly, there's enough people that I know that are clinicians that were willing. The membership is, I don't know if we scroll through that slide, the membership's not that expensive. I think for the entire system, it was on the order of $15,000. And so there were enough people that would have donated that money, but I did not think that was the right way, because I think the system has to be invested and know that it's happening instead of a bunch of individuals trying to push it through. So it took a couple iterations of who to go to and the leadership kind of ladder. And in my other roles, as I've communicated with people, I've just kind of been dropping that this is something that I think is important that we should work on. And we've had a couple transitions in leadership in our administrative side of the hospital, in our C-suite of the hospital. So that was also a challenge at some points, because people that were ready and on board and going through it then were gone. And so I had to have a conversation. But in the end, it was perioperative services. The chief nursing officer, who also was over perioperative nursing, perioperative services. Again, the OR being the biggest offender, and me going, I mean, that was where they felt was the best fit. So they have sponsored it. This coming year, it's Dan Lundergan, and I mean, the hospital itself has just decided that it's worth seeing how we can do with it. So it's now a little bit more of a broad sense of the use system in general, but before it was perioperative services. But even within perioperative services, they had extended the membership for the entire institution, not just the ORs. So we'll see. Any suggestions or advice would be welcomed.
There's plenty of other departments. Cardiology.
Oh, well, everyone's included. Every single membership, every single department. The membership includes every department. It is for the entire system and all of the employees of the youth system.
I know the waste that goes on just within cardiology.
Oh, yeah.
Procedures
Oh, God. EP lab makes me cringe.
matches what you see in the ORs.
Yes, it does. EP lab is painful. Not quite as painful as the OR, but there's tremendous opportunity everywhere. And again, I think a lot of these things, a lot of people want to do stuff on their own, which I think is amazing. But Joan and I were having this conversation prior to this lecture. But and I think it's important that we all, live as we preach and things like that. But the system really has to make some big changes, and a lot of it is based in, for cardiology example, like how we purchase. And you guys are actually using reprocessed wires for certain things, which is awesome. And so having those discussions, a lot of us as clinicians don't know about it, don't know what the options are, don't know much how much we spend per case in the OR. And so I think there's got to be, we have a lot of value engineers and people at the hospital that can help us with this kind of decision making. But if our decisions are educated with green in mind, I think that's going to be a big help to us. Yes. Oh, sorry. Are you my runner? I can run it.
Well, I really agree that a lot of it has to be system change, and but there has to be a really grounds up kind of thing as far as educating, not just clinicians but staff, and So how is that approach? How are you working on that approach?
I want to clarify. So a bunch of people to thank. Like, this is so not just me doing this. I'm like, for whatever reason, I'm just the mouthiest one. But and again, like a lot of my slides, Jody Sherman and Yale, they did a tremendous amount of research to enable this kind of literature to be out. But so there's a whole bunch of people that have been doing stuff. I mean, Joan has been doing stuff for decades. But in the operating room alone, since I've been here for 12 years, there have probably been 3 attempts at recycling in the OR itself, and they've all failed. And my opinion, humble as it is that it was a lack of education. Like, the staff didn't understand why we were doing it, how to do it. No one ever really engaged the people on the ground that were doing it, how to do it. And then we got cited for JACO for one of them, went back when we were with JACO, because of where the recycling garbage was sitting, because it had to be taken by a separate group, and all these things just hadn't been figured out. And so that's another reason why the hospital has to buy into this, and why each champion matters, everyone together, is that it's got to be rolled out in the right ways. Like, we can, the HVAC system, yes, the hospital can do that, right? But anything that involves personnel, whether it's nurses, clinicians, MAs, the housekeeping services, facilities, engineering, it has to be educated and it has to be rolled out appropriately. And so there's got to be dedicated time to figuring out how we market it, but educate, how we sell it, how we implement it, and the people on the ground have to be in the process of implementing it. If if there's nowhere to store their trash for this trash they're separating, then we've got to figure that out, and then that's where the hospital comes back in to say, well, this is what we need to do.
Part of training of all new staff and clinicians. I mean, you need to do it across all things, but just catching them right when they come in.
And hiring process, right? That's one of the things Practice Greenhealth talks about is if you create these changes, but eventually that change gets to HR and how you hire and the culture that you are hiring for is built into your hiring process. It's built into your goals and part of your administrative goals for your job. That is all ways to really ingrain sustainability into the culture of our workspace. How am I? We're going to have to talk about that. I mean, this is why I think who you go to matters, and I'm very happy at the response so far initially gotten from the CO of the hospital to say, this is important, we should do this, because in the end, it is going to take a lot of strategic effort, and everyone. But to your point, it's going to be top down, but bottom up. It's got to come from both sides, not just one. Does that help answer? Okay.
Oh, sorry.
I feel bad, Joe.
No, that's okay. Thank you. That works.
Well, thank you for the presentation. I thought it was wonderful. Can you hear me okay? So I really had more of a comment than a question. Just I loved what you said about potentially taking the cost savings that you find and putting them into some type of an account or bank or something to spend on areas that don't particularly have the cost savings. So in food services, in our cafeteria, we have over 3,000 customers a day. And right now we're using styrofoam plates. But if we were to switch to something that were compostable, it would triple our costs. And so we've been shut down, when we've proposed that in the past, because there hasn't been the cost savings associated with it. And same with recycling. I mean, I don't know if people know that we have a pulper in our dish room. And so we can decrease the size of all of our garbage from like 10 bags down to 1. And if we had something that was compostable that we were using for disposables, we could send that off to a company that could actually compost it for us. But again, all those costs are associated with it. So I do agree with you that I think it needs to be strategic in our approach and that we need that support because, food services is important. Right.
I think that there's got to be a dedicated eye to this, right? And there's got to be, and that's why when I've already asked you guys for your data, right? Like I think even if it's retroactive or we're looking at it in its past form, when we have to be able to, I mean, again, we can all do the right thing to some extent, but it's still a system and it's still a business. And so at some point, we have to be able to get the basic metrics to show what our changes have done from an environmental standpoint, but also a financial standpoint. And I've already kind of breached this. We have a clinical value committee in the hospital that I sit on. And I brought this up there. I said, value is also when we save monetarily in one space, then creating value by paying that forward to do the right thing in another space is, we have to be, that's strategic, and you have to have that kind of oversight, but you also have to have those numbers. And so there's going to be a lot of organization around to how this is structured, I think. But then once that gets in place, hopefully things will get better. I do think this year, hopefully it's just a year, to kind of figure out the best way to create that strategic plan is going to be really important and crucial to how this succeeds or fails.
So there's also value in letting people know about what is happening, so that medical students start choosing this school, this medical school, this health sciences campus because of what the hospital is doing and the practices that they have put in place, and the patients start making those choices for university hospital or other hospitals because of the sustainability of our hospital and of our health sciences program. There was another.
Thank you. Yes, putting a price on carbon is often touted as the foundational measure to get so many of these things started. Widely promoted by climate scientists and economists. And my question is what effect would a price on carbon have on all the things you're trying to accomplish here?
I started having that conversation actually with our administration recently, and it didn't start with that question. So we'll have to expand on that in a second. But we started talking about waste and how much, and he's like, he was like, I will advise you to not discuss waste as a cost option because for whatever reason, our waste in Utah, we still have landfill space versus other states, is dirt cheap. And so the price for coal, again, I think every region, location, every institution has different pricing, but I think it's a valid point. But then their ask, which I don't have answers to, and this is why we need someone dedicated to these roles, is then how do we supply our energy and what's the cost? What's the lead up cost for placing these panels or these wind machines or whatever it is that people are asking for? But we need to have cost analysis built into some of these things, which they have to be able to support, to provide. But if you don't ask the question, you're right, we don't know the answer. And so I don't think, I'm still finding out, but I don't know that these questions have been asked here. I think these conversations seem to just be starting. And again, people are doing great work individually. I mean, Robert Armstrong, sitting right behind you, has done amazing work in facilities too. But, he's one guy, he needs help, he needs support, he needs to be empowered to do more. And so I think that those are great questions that we need to be asking.
Hi, thank you for your talk. I really appreciate it. I just wanted to know what your thoughts are on the future of medical students and medical education in this realm. I know Chris has done an awesome job getting involved with Practice Greenhealth, but we have so much interest in our classes and moving forward. It's something people love to talk about. We had a student lunch and how many people showed up? There were a lot. 80 or something, and it was incredible. So I'm just wondering, is there a space for it in research and leadership, and how you see that moving forward?
I think that's a great question. I think, yes, Chris is doing, and he's one of my colleagues, Danny, is on curriculum, and everyone's working to see if we can get actual course material kind of geared toward this, because I think education is going to be the key. But there's also, I think we need to collaborate more. One of the things, there is a search going on for a new position at the U, the whole U, the one U, for a chief sustainability officer. And I think that's going to be a great platform to jump off from and to expand on a lot of these things. And one of those things is even just I'm on that search committee, and one of the benefits, amazing things of the search committee is having met all these people from main campus and starting those relationships of creating collaboration. We have such a unique, it's a double-edged sword, because one of the problems and one of the reasons they're hiring a CSO, this role for Chief Sustainability Officer, is that the U has renewed or their pledge to the climate commitment, and healthcare, because we're on the campus, is now a part of that. And that sucks for them, because we are by far the going to be the hardest challenge of this whole institution. And so 3 of us are represented on the search committee from healthcare to make sure whoever comes into this role knows that this is a big portion of what they're going to have to do. And we have people here that have been interviewing through the healthcare interviews. But one of the things that we hope to also promote is this kind of collaboration. We have so many assets on main campus for research, for innovation, and that we don't yet have pathways for. And as individuals, people have gone out and done things, but there's not pathways, nor is there that kind of awareness that we can create these pathways and do things for you guys, right, to improve research, because there's going to be a lot of research that's needed to be figured out, even just to get benchmark information. We were talking about how do we show our improvement, and energy, and how are we measuring the things we need to be measured? Are they all being measured? Are there other things we should be looking at? And so there's going to be a lot of innovation and research that has to come. And I think that for these kind of scale of things, we have public policy people. There's a lot more we can do. And I do think leadership opportunities as this grows will open up. I know now part of the discussion that I'm having is when that person gets hired is that we should have someone at Health Sciences or multiple people that report to that person, right, that are charged with healthcare in this institution as a focus. And so opening that door, and then each department having, just like you have a chief quality officer, you have a chief sustainability officer for each department that's monitoring your department's progress, right? That's kind of, as Practice Greenhealth lays out kind of a structure for the hospital, is to have little groups of people, get away from the silos, but you're still going to have individual groups that have their champions that report up, to some entity, so to speak. So I'm hopeful for you guys, and I'm kind of banking on you guys to make things better. So we got to figure something out, because we definitely have not helped. That's right here, front row, okay? But yeah, Chris is, that kind of energy, is amazing. And I think unless he's kicked me off, I'm still technically your faculty sponsor. Yeah.
More questions? Where's Dr. Good on all of this? Have you had an opportunity to take this to Dr. Good, or it is
in a meeting that this is, I think, something we should focus on. That was also in his first 3 months of being here. He probably does not even remember the interaction, but the problem with sustainability in my very new B experience is everyone's on board with it. Everyone is absolutely in favor of it. It makes sense. It's the right thing to do. And then it's like, so what, right? So then how do you put your, money behind your mouth, that kind of stuff. And so I think those conversations are being had now. And you should tell us, I don't know the conversation. There's been a long history of how things have gone and committees that have existed and they've gone away, again, based on someone leaving the system, then the entire, committee drops. And so I think my strategy, and Joan has given me some blessings on this, is to have learned from the stories she's told in the past of why things failed, right? Failure's good, it teaches you. So I think we're trying this in a new realm. I think that the Michael Good part is really going to be impactful for you guys. And I think you guys will have more of a voice with him almost than anyone, because the students he has a strong commitment to the students. And so I think it's going to have to come from that side. I think the side that we've been focusing on is the system and the hospital side, mainly, to where, of course, he has a say in it, but kind of more the administrative buy-in of the system. But he's definitely, obviously, someone that needs to be in this conversation.
So, in partial answer to the question, there's something that's going on right now on our campus-wide is this strategy refresh. And it's looking at strategic planning. And if all of us are including sustainability and taking action in terms of sustainability within our strategic plan refresh work, then we will be sending that message also to Dr. Good and to the university administration that you will have support if you do this. For the library, we have included it in building a culture, and we've said of sustainability, of wellness, of diversity, of inclusion. So those are values that we have in the library, and we want those to be part of our strategy refresh, our new strategic plan. And the campus has put forward safety, diversity, and 1U. So all of those can be worked into that part of the strategy refresh. So that's one way that you can make a change or foster sustainability within your own units, colleges, departments, programs, etc. But then as that gets communicated up to Dr. Good and to administration, then that is a way of changing the system from the bottom up, while there's processes that we know about that are happening that are systemic within the hospital that's showing that this matters. And when then there's this the change in all the different realms, it seems like it's a change that makes sense to do, and that you'll be supported as a leader in doing them. I'm going to take where a question hasn't come from. Thank you.
Talking about systems, it was interesting to see the other medical institutions that are supporting this initiative. What kind of state support or I guess what I'm trying to say is the state supporting you in this direction?
No, there's an anesthesiologist, Suzanne Harrison, who is on the legislature last year. It was her first year, and she is very committed to clean air as a concept. And so we have been working as, the healthcare side of that to bring forth a bill to help address this from a kind of an institutional aspect. She is working on that and taking the lead on that, but that's the only avenue so far that we've had in terms of state funding or sponsorship or support. But any suggestions or inroads? But next, yes. It's great. I mean, I think there is precedent for it for policy. Again, not so much in this country, but in other places. But and that is one thing we're looking at, is what are the policies around the country that we could use to cite precedent for creating some sort of change.
So kind of the collaboration between Utah Moms for Clean Air, Physicians for Environment, maybe a committee that can actually lobby.
Everybody together, yeah. It's a good idea. We should talk.
I think this is going to be the last question.
Yes, if you're still at the stage of looking for models that are nearby for sustainability, Weber State University is such a model, has been recognized for maybe 10 years or so. They hold a conference each year, and they've done some really good work, saved a lot of money, very similar to the campus as a whole, absent the medical procedures. And also to the north of us, Idaho has a conference which is multi-campus. Boise and Pocatello and other campuses do it simultaneously through video conference. And that might be a model for Utah too, with Weber State and Utah and elsewhere.
Our higher ed has, a more long-standing road than healthcare for sure. Universities have been working on climate, East Coast, carbon neutrality, and but that would be great to look into for the U's model. And when, the hope is that this person will start in early 2020, the Chief Sustainability Officer, and so that would be a great thing to propose to them, is to look at our nearby institutions that have done well and take, because every landscape's a little different, the culture's different a little everywhere, so I think our regional partners that have done well would be great to look at. But that'll definitely be something that hopefully this CSO, that we will suggest that they look at. Thank you.
All right.
Thank you, guys.
I want to say thank you again to Smitha. And I want to remind you that next time we have two students who have been involved in getting changes at the Utah State Legislature in terms of climate change and what the state of Utah says about climate change, and talk about their journey, also involvement in the climate strike. And then our last session will focus on the University of Utah's climate commitment and the re-signing of that commitment, and what is behind that, what plans are for the University of Utah. I also want to remind you of a couple of things that I forgot to mention in the beginning. One is, if you need CME credit, there's a CME code for today, 309152. You have to enter it before midnight in order to get today's credit. We are encouraging everyone to bring water bottles for the sessions. So if you're coming next week or the week after, please bring your water bottle so that we don't have to use plastic cups. And these are kinds of changes that can be made in your own department. There's information on the back that is on green office certification, which is available through the Office of Sustainability here. And the last thing is that I mentioned earlier, the session is being streamed, so your colleagues can watch it from their desks, and you can come here so you can ask questions and get food. And they're also being recorded and being put in our digital collections, which Nancy Lombardo manages here in the library. And so those recordings and previous slide presentations from the sessions before today are accessible in our digital collection. It's linked in the, how many copies of that email did you get from me? In that email, and every single one of them, that there's a link to that live guide that will link to the videos that Sky has produced for us. And as always, it takes a village of people, and Smith has just told you that you are the village for healthcare. We are the village for healthcare, for University Hospital and UHealth to make these changes to show Dan Lundergan and Dr. Good that this is what is needed to assure that our medical students, our nursing students, our pharmacy students, dentistry and health students have a livable future. So thank you very much for coming today and for participating in this series.